Okay, now let's proceed to resolving the ABO discrepancies. Because most discrepancies are caused by technical mistakes, we follow a systematic resolution process starting with simple clear checks before moving to complex biological investigations. So here is how the specific actions you can do in order to resolve these discrepancies. So first is to repeat the test with the same sample. So to exclude technical errors made during the initial testing process, repeating the test ensures that the discrepancy was not caused by clerical errors such as transcription mistakes or procedural errors such as failing to add reagents or sample, using the wrong reagent, misinterpreting a weak reaction. If the repeat testing provides matching results, the discrepancy is resolved immediately. Next is to wash cells prior to testing. So in order to remove interfering substances from the red cell surface or the plasma environment. So through washing of the patient's red cell, removes excess proteins seen in conditions like multiple myeloma that cause the cells to stick together physically, which mimics the true agglutination. So for Wharton's jelly, in cord blood samples, washing the cells 6 to 8 times removes the viscous contaminant causes non-specific clumping. Neutralization, or the BGSS, some cancer patients have excessive soluble blood group substances in their plasma that neutralize the laboratory's anti-sera before it can react with the cells. So washing removes these substances to allow a clear forward typing. So we also have cold autoantibodies using warm saline or 37 degrees Celsius to wash the cells can elute or strip cold reacting autoantibodies that are causing the cells to agglutinate spontaneously. In testing a new sample, we eliminate errors related to the original specimen's integrity or identity. So obtaining a fresh sample resolves discrepancies caused by specimen mix-ups or misidentification during collection or contamination of the initial tube. It is also a standard protocol when the current test result disagrees with the historical blood type on record for that patient. So test to detect unexpected alloantibodies. So to identify non-ABO antibodies that are reacting with the reagent A1 or B cells in the reverse typing. So some individuals have cold reacting alloantibodies such as anti-big M, anti-big P1 or anti-big L small e or the anti-Lewis that react at room temperature. By performing an antibody screening using group O reagent cells which lack A and B antigens, we can identify these extra antibodies. So once identified, the reverse typing can be repeated using reagent A1 or B cells that lack the corresponding antigen, resulting in a valid back typing. Now let's review the patient's record. So to gather clinical context that explains biological causes for weak or extra reactions. So age and diagnosis. Records can reveal if the patient is a newborn or elderly or has a condition like leukemia or hypogammaglobulinemia, which explains missing antibodies in the reverse typing. Transfusion or transplant history. A history of recent group O transfusions or a bone marrow transplant explains mixed field reactions. Mixed field reactions meaning two different cell populations. And then medications, so reviewing records for drugs like daratumumab or certain antibiotics can explain interference that mimics a positive antibody screen or autologous control. For historical type, we can compare the current results to the previous records. It's a mandatory safety check to ensure the patient's blood type has not changed due to specimen labeling error. So information regarding a patient's medical history and the specific characteristics of laboratory reactions are essential clues used to identify the root cause of an ABO discrepancy. So here's a comprehensive tips or that will aid you to resolve the different discrepancies. So patient's gender and age. So gender, while ABO inheritance is generally the same regardless of the gender because the genes are on autosomes, Gender is vital for clinical management in urgent situations where a discrepancy is not yet resolved. Group O Rh negative blood is strictly reserved for females of childbearing potential to prevent future HDFN, while Rh positive blood may be given to males or older females. For age, it's the most critical factor for Group 1 discrepancies, in which Group 1 discrepancies have weak or missing antibodies. Again, newborns do not produce their own ABO antibodies until 3 to 6 months of age, so any antibodies detected are maternal IgG. Conversely, antibody levels naturally decline in elderly patients, which may result in a missing reaction in the reverse typing. For the diagnosis, a patient's clinical diagnosis often points directly to the biological cause of a mismatch. So, leukemia or lymphoma, these conditions can depress antigen expression on the red cells or in the group 2 or lead to low antibody production, such as in the group 1 ABO discrepancy. So, multiple myeloma or Waldenstrom's macroglobulinemia, these cause high protein levels leading to a ReLU formation, such as in group 3 ABO discrepancy, where cells stack like coins and mimic agglutination. So we also have gastrointestinal diseases. Disorders like colon cancer or intestinal obstructions are linked to the acquired B phenomenon or the acquired B antigen, where bacterial enzymes make group A cells react quickly with your anti-B reagents. So you also have stomach or pancreatic cancer. This can produce excess soluble blood group substances or the BGSS that neutralize the laboratory testing reagents, causing false negative forward typing. For history of transfusion, so knowledge of recent transfusions is necessary to resolve mixed field reactions such as in group 4 ABO discrepancies. If a group A, B, or AB patient was recently given group O red cells, common in transfusion emergencies, the laboratory will see small clumps of cells or the patient's red cells in a sea of unagglutinated cells, which is the donor's O cells. Massive transfusion can also result in passively acquired antibodies, where the donor's antibodies appear in the patient's reverse typing. So for pregnancy, a significant FMH where the fetal blood enters the mother's circulation can result in a mixed field reaction in the mother's forward typing if the baby has a different blood type. Pregnancy is a sensitizing event that can lead to allo antibodies like your anti-Big M or anti-Lewis A that react at room temperature, causing extra reactions in the reverse typing. For medications, we have immunosuppressants. These drugs can cause hypogammaglobulinemia, leading to missing antibodies in the reverse typing. We also have medications like IVIG or the RH immune globulin can introduce unexpected antibodies like your anti-A, anti-B, or anti-D into the patient's serum, creating extra reactions. There are certain therapeutic agents such as daratumumab for multiple myeloma, interfere with screens, and can mimic autoantibody activity. And lastly, for the grading of results, the strength of the reaction in the test tube is the first indicator that something is wrong. So ABO grouping typically yields strong 3 plus to 4 plus reactions. So if we see a 1 plus or a 2 plus reaction, that reaction is usually the discrepancy and needs investigation. So investigation such as there could be a presence of a subgroup or there is a ReLU formation. For mixed field or the MF, this specific grading, small clumps against a smooth background, and always indicates two different cell populations from a transfusion. So a bone marrow transplant or a specific rare subgroup like A3. Now I have here some cases for you to solve and analyze. So in case 1, a 96-year-old man was rushed to the hospital ER for a fractured pelvis. So the following is the result of his pre-transfusion testing. So let's look at the results in the forward typing. So this means that the patient's red cells have B antigen because anti-B reacts strongly which gives you a 4 plus reaction. So forward typing says blood group B. In the reverse typing, if the patient is group B, his plasma should contain anti-A antibodies. Therefore, it should react with your known A1 cells, and it should have a 4 plus or a strong reaction. But in here, in this case, A1 cells is 0 or no reaction. The B cells is 0, and it is correct since group B should not have an anti-B. So the problem is there is a missing anti-A in the reverse typing. So what's the discrepancy? This is called now the group 1 ABO discrepancy, in which it is linked with weak or missing antibodies. So the forward typing and the reverse typing do not match because the expected antibody or anti-A is missing. So what's the clue? The patient is 96 years old, and in elderly patients, the immune system becomes weaker. They may produce weak or missing ABO antibodies, and then reverse typing reactions may be weak or absent. So this explains why there is no reaction with your known A1 cells. So which result is correct? So the forward typing is usually more reliable in elderly patients. Forward typing clearly shows strong reaction with anti-B, which is 4 plus, strong reaction also with anti-AB, which is 4 plus. Therefore, the correct blood type is group B. So how are we going to resolve this problem? You can repeat the reverse typing, incubate the serum with A1 cells at room temperature to enhance weak antibodies. So you're going to review the patient's age and clinical history. So check for hypogammaglobulinemia if needed. Usually, the weak antibody becomes detectable after incubation. So what is the patient's correct blood type? So the patient's correct blood type, so from the forward typing and RH typing, so the patient's correct blood type is now B positive or BRH positive.